Yeah, cheers. Thank you. Right. Okay. So the question we want to answer, Michael Douglas was giving a shocking revelation that oral sex gave me cancer. Then after that, it did say, oh, in the same Sun newspaper, no, it didn't give me a cancer. Okay. So which one is correct? That's a real question. You do come across from the patient's perspective or family perspective. We all know smoking and alcohol is one of the predisposing factors for head and neck cancer, but there is a hidden danger, that's a HPV virus. So this talk is mainly focusing on etiology, epidemiology, a little bit of treatment, and some trials and prevention. 1983, all of you know, Oxford University refused to give doctorate degree for Margaret Thatcher. The reason is I like this because the educational institutions stand for the rules and regulations. It doesn't matter whoever you are. But the most important point is 1983, the research just started showing HPV might be an agent involved in certain oral cancers. 1983, we're talking about. And 1985, that's the most important year for Michael Jackson. The album Thriller came to the top and stayed for 36 weeks continuously on the top. That's great. But in our area, Learning et al. First extracted HPV virus or DNA from by Southern blot technique, 1985. We all know 2007, first iPhone was released. At the same year, WHO first recognized HPV was the cause for oral cancers. So it's a long journey. That's the research. Sometimes you throw some coins in the research. It takes minimum 25 to 30 years to come into the practice. That's the reality. Young female come to the clinic with a lump in the tonsil, the neck lump. You've done all the scans and examination, biopsy, and you're telling you got a HPV cancer or just cancer. Patient asking, I never smoked, I never taken alcohol, I'm too young to have this cancer. But that's what's happening. Okay? They're just about to start the family, come with the partners, small 3-year-old children, or 5-year-old child. But on the other hand, there's a 68-year-old man with a heavy smoker, alcohol, comes again with a large tonsil mass, small neck node. Then you do the same investigations, you're telling HPV negative cancer. So what's the difference between these two? Why this is we say it's clearly a different disease. So what is genital HPV? It is most common sexually transmitted infection. We have more than 40 type of subtypes. Many people, they got infection, but many they don't know they got this infection. And there are high risk and low risk types. The high risk ones are 16 and 18, to some extent 6 and 11, but the low risk ones can cause genital and anal or mouth warts. The interesting things you need to notice, don't get alarmed too much. Most of the infections goes away. It is similar to the tuberculosis in India. Everyone got exposed to it, only very few get the tuberculosis. Yeah, it's same. HPV is also like that. This is kind of warts. This is not a cancer. Again, it appears like a cancer. It's a warts again. I'm not really sure whether I can put this poll at this point. But anyway, what I really wanted to ask the online audience is, in the Western world, there is increase of incidences 6 to 80. The answer is yes or no. What do you think? The answer. HPV is on the rise. Around 60 to 80% of oropharyngeal cancer is HPV. Yeah, that is yes, that's true. The second question is, HPV-related cancer is sexually transmitted disease or not? Yes or no? Yes, pretty much yes, that is correct answer. Third, partners of the patients with the HPV positive oropharyngeal cancer seem to have elevated oral HPV infection compared with the general population. Yes or no? The answer is no. Okay, so no, that's an important question you need to tell patient or the partners, like you don't have any high risk at this point of developing. That's evidence doesn't show that the partners doesn't have more increased incidence of HPV oropharyngeal cancer. So that's the message I want to pass from that slide. So it does affect younger people. It is related to the changing sexual behavior, and smoking-related cancers are on the decline, probably due to health education. But HPV-related cancers are on the rise. Partners or the patients with HPV positive oropharyngeal cancer do not seem to have elevated oral HPV infection compared with the general population. It's the same general population risk what they got, so you can reassure them. Okay. It's a trend in Scotland. You can see the bottom line is the female, and blue is men, and gray is for combined. From 1989, it's almost, it goes 3 times or even 4 times higher, 350 cases, 2013 itself, we diagnose annually HPV positive or oropharyngeal cancer, and 80 to 85% in Scotland is HPV related. So what are the risks here? Partners, yes, high number of sexual partners, high number of lifetime sexual partners, and sexual preferences, and the timing of the sexual things is all related. There's a lot of evidence suggests it affects younger people. And is it related to the socioeconomic status, high socioeconomic state? Not really. That's a myth, to be honest. It affects all the people because it affects a little bit wealthy people. That's why they say it's projected in more in that way. It affects equally in our areas. That's a nice study, hopscotch study, to understand whether we can identify the high-risk people. So it's nearly 5,000 samples from the dental settings, from the saliva is being extracted, and see how many are going to get oropharyngeal cancer. But the HPV prevalence is only 5.5. It's not very high. That's what it's picked up, the study. Then it said the screening is not possible. So that's the important thing. But it does show changing sexual pattern. That's more than 90% practice oral sex, and whether it's same for male or female. So that's the important thing. The next thing is how does it cancer? How it become a cancer? Is HPV infection is automatically become a cancer? Not really. When we have a HPV in the mouth, probably there is some damage, mucous membrane damage. Then it goes into the basal layer. Then there are some other factors manipulates. For example, the immunity of the person, concomitant use of tobacco and alcohol, and the transforming growth factor beta gene genetic variation. Some people with genetic variation develop this cancer, and also concomitant HPV infection like HPV-8. That's why the more and more use of multivalent vaccines is on the trial. This point is a slightly complex slide, but it's very important. When the virus enters into the cell, it expresses 2 proteins. One is E6, other one is E7. That automatically binds into the P53 and retinoblastoma proteins. Those 2 proteins are good proteins. They're supposed to stop the spread of the, or not the spread, division of the cells. Those 2 cells inactivated. When they stop, the cells grow continuously. That's why it's become a cancer. So, but it's supposed to be in cervix. Why it's in the tongue base, why it's in the tonsil? Because all the 3 share similar histological appearances. That's why we get the same cancer in the cervix and same cancer in the tonsil, tongue base, to some extent in anal canal and penis as well. So it does present young people. The important thing is it can be a small primary, and or you may not detect the primary, it's unknown primary, or it can be a large secondary node, and usually present with a cystic metastasis. Last but not least, it may not have any symptoms at all, and that's very different from the HPV negative cancer. They have a pain, trismus, or some kind of adenophagia and other things. You can see here like smooth mass or ulcerated mass, some kind of exfoliative mass, or you can see a large cystic metastasis, painless lump, or unknown primary like this, or large node involving level 5 and level 4. These are all common. And the Sudarshan gave this slide, and it's tonsil primary with a metastatic neck node. And so how do we diagnose? Commonly used the P16 immunohistochemistry and PCR. PCR is slightly expensive, probably it might be cheaper after the COVID. But presence of HPV doesn't mean they got a cancer. So they need to have either viral oncogenes or antibodies to these, I said earlier, E6, E7 proteins. That is the definite criteria for HPV. Histologically, it's very easy. I'm not very expert in the histology, but you can see here, you can see a full, nice keratin formation. That's a HPV negative cancer. That's a proper cancer. This is more basaloid, more bluish in color. So that's the difference between this P16 immunohistochemistry. I just want to highlight about the cancer staging. This is the first time in the history the causative agent is used for staging. So if you have HPV positive cancer, your staging is very different from HPV negative cancer, because it's based on more like a nasopharyngeal cancer. And there was a nice paper, it questioned the staging, and they said they should have a different staging system because of the good prognosis. So in general, the nodal classification is like N1 is less than 3 centimeter, N2 is like kind of 3 to 6, and some contralateral, bilateral, and that's kind of classification for general nodes. But for HPV nodes, you can see N2A is moved to N1, which is the node can be up to 6 centimeter. Still, it's N1. Previously, N2B is also moved to N1. So it can be more than one node. So in simple terms, any nodes, any number of nodes less than 6 centimeter still considered as a N1 if it is HPV positive. If it is HPV negative, slightly different staging. And the N2Cs become N2. So pathological staging is slightly different. That's used mainly for research setting, but that's what probably it's useful as well in future as well. Up to 4 nodes still considered as a low risk HPV cancers. That's where a lot of discussion going to happen today about the escalations and different trials and all these things. So HPV positive and negative cancers, there's a slight change, which is extracapsular spread. That's the message I want to pass. That is one of the main risk factor, and that decides a prognosis. So the treatment, a lot of debates going to happen. Main mode of treatment is radiotherapy, plus or minus chemotherapy. Again, surgery, either oral surgery or robotic surgery or laser surgery or external surgery. These are all debatable now, or multimodality treatment. And then discussion about de-escalation. Are we over-treating these patients? So the biggest question is it surgery or IMRT? I mean, 2 important trials I want to quickly touch base. They will discuss a lot. This ECOG trial. The idea is about, can we reduce this dosage safely without compromising the cure? Okay. And how do we risk stratify these things? How much margins, whether extracapsular spread, how many number of nodes. So these are the points will be discussed, and probably in next 3-4 years, we know exactly what's going to happen. Many trials are almost recruited, most number of patients, and even the preliminary results are coming out as well. And the next one is Oropharyngeal trial. Again, that's probably the first trial. There's a lot of limitations as well. You will hear more about this trial in today's discussion. So general point of view, the prognosis is generally good. Yeah, that's the important thing, whichever way you treat. So this is the paper I want to really quote, this is recently published, 2021, European Head and Neck Journal, Systematic Review and Meta-Analysis. This is level 1 evidence, which has got nearly more than 5,000 patients, IMRT 4,000 patients, and TORS 1,300 patients. You need to understand, majority of the patients in IMRT arm treated by chemotherapy as well. That's not single modality treatment. And majority of patients TORS treated by adjuvant, either chemotherapy and radiotherapy or radiotherapy. But the interesting point with a TORS patient, even though 67% treated by multimodality treatment, only 30% only had a radiotherapy, and the 40% treated only transfer robotic surgery alone, and the rest of the 30 had a chemotherapy and radiotherapy. And the staging wise, both of them compared like to like, and almost 70% of them in the both arms are early cancers, T1 and T2. That's a good news, because we are picking up this cancer all around the world a bit more earlier than predicted. Previously, it was like a symptomless cancer. It was late presentations. Now there's a lot of awareness about the HPV cancer. They present early. And this is free survival. In the IMRT curative survival is 83 and 91.3 in the TORS subgroup. There is a bit of limitation there, but it shows TORS group has got a slightly 10% more survival rate. And disease-free survival rate is difference is 79 for IMRT and 89 for TORS. I could slightly argue that TORS will be more selected patients, highly selected patients. That's why it shows, I think in my view, the survival is same for both IMRT or TORS. It's up to the patient's choice to decide. And the tracheostomy dependence and feeding tube dependence are both pretty much same in both arms. So this is a good recent, highly evidence-based paper and released last year. So whatever the mode of your treatment, if they continue to smoke, the prognosis drops. So that's important advice you need to give it to the patient. And the challenges are younger patients, chemoradiotherapy is a one shot. Scottish life expectancy is around 89. If they get a second cancer, what are you going to do? And the management of recurrences and second cancers, and these are all things. Prevention, the Gardasil is kind of gold standard for boys and girls at the age of 11 and 12. Gardasil is a 4 virus one. Cervarix is only 2, 16 and 18. And in UK, as well as other Western countries, the boys and girls being vaccinated around the age of 12 and 13. So why it is important? They have to be vaccinated before the sexual exposure or the infection. And it won't prevent cancer when it happens after 20 or 25. And 3 shots over 6 months period of time. And even now there's a debate. It's not a contraindication when the patient has got a cancer. It becomes ineffective. But having said that, there's one trial in Australia is focusing on immunotherapy and HPV vaccine to see whether it is beneficial or not. So these are all different preventions, but still the screening is not very effective for this type of cancers, and that we need to understand. But early detection is important because that's how you can give a better prognosis. Like that's where close observations, early referrals, NBI, high definition scopes, high index of suspicion. These are all very important. You can't just dismiss the fact that patient with a painless lump has been there for 2 years or 1.5 years, slow growing, intermittently cystic, and you aspirate, it goes away, comes back. That's not a deal. You need to have clear understanding about this pathology. So this movie is supposed to play, but it won't play, I knew that. You need to be smart. So you need to understand what's going on, because everybody's looking at, some patients comes to me, I want to be a part of Pathos trial. Okay, I want to have a robotic surgery before they know what's going on. Yeah, so important things are, yes, it is a potential threat for future, at least for next 20 years, in my view, because HPV vaccine only started only 4 years back. So it will take minimum 3 decades. That's what the scientists predict to give a beneficial effect on the human population. So we're going to manage this for next 25 years. So it's good for my job anyway. And it is sexually transmitted disease, unfortunately, and it commonly affects tonsils and tongue base and younger age, non-smokers. And there's a debate about the mode of treatment and vaccination. Screening vaccination is good, is not effective for cancer patients. The screening is, in a modified way of screening, is good for improving the prognosis. Thank you. I'm happy to take any questions. Why HPV vaccine is not given for boys? Actually, yeah, it's been approved, it's been given, but there was a delay due to economics and resources. That's what I've been told, but it's been given. I'm sure it's been given in Germany and other areas as well.
Can I just make a comment?
Please.
The problem with the vaccinations is that the acceptance is very difficult between the countries, right? So I guess the best country is Denmark. I found out nearly 90% or more than 90% of people, young kids, get vaccinated. In Germany, it's a really sad story. Even in the States, they started very well, but then it dropped off. Only a few girls actually get this 3rd shot or the 2nd shot even. So the whole success of the vaccination works only if everybody gets vaccinated. And the UK was very late with vaccinating the boys.
Yes.
Germany was very late, just 3 years ago, 4 years ago. So we'll have to wait another 30 years to see, but we have to go in public to motivate parents, have their kids vaccinated. I think that's the main issue. Absolutely. Internationally.
So you're telling a very good point. It is about the herd immunity. So there's a 90% of the people needs to be vaccinated. So vaccinating only girls is not going to protect. So it needs to be boys also needs to be vaccinated. And in fact, boys also getting other cancers as well, not only, so that is important. If anyone, there's a lot of questions. Okay. So HPV positive with the HPV positive, the modality of the treatment, or negative with the positive, the modality of the treatment. Yes, I think you will have a further discussion in this, in the debate as well. So even there is a lot of change in the HPV negative cancers, whether we should go kind of surgery followed by multimodality for chemo-RT to give a best cure. But the prognosis is relatively bad, I would say 60% on the other hand, HPV positive up to 90 in early stage cancers. So can HPV be given to adults? That's a question. Yes. The answer is only in research settings. It's not, yes, they can have adults if they are not sexually exposed before. Some adults, the proportions are very, very low, I think. Yeah, it can be given. The idea is vaccination should be given before the sexual exposure. And does vaccine lower the risk of HPV infection or cancer occurrence? Yes, it does. It's been proven it does lower the infection. That's already showing in the cervical cancer. So the recent report from Scotland, cervical cancer, already they are seeing a significant reduction in the screening. So yes, it extrapolates into cervical cancer. They call it WIN 2, 1, 2, 3, something like that. There's dysplasias, it's all going down. So it's not my boss, Win Pellery. So yes, answer, I think it will extrapolate into the tonsil cancer as well. The role of biologicals in treatment for oropharyngeal cancer, such as tonsil cancer. When do we apply biologics? That's a great question, but at the moment, I think the research, it's all in the research setup. It's not giving any, we can't give any treatment recommendation with this one. And a woman with a cervical cancer in the past, does she have a higher risk of HPV oropharyngeal cancer as compared to the normal population? The answer is no. That's no evidence suggests that previous cervical cancer has increased risk of. But some papers say oropharyngeal cancer patients have like small risk of developing anal cancers and everything. But I did a lot of research in that, but it's not shown any increased evidence. Is there any benefit of vaccination if patients are already sexually active? Answer is no. There's a difference between IMRT and robotic surgery with adjuvant treatment. Significant. I think you're asking the question, or you're just saying what I said. I think that's right. So in TNM 8 US, would there be a difference of treatment of HPV positive and negative? That's a good question. So the staging is just for prognosis. There's no strong evidence to suggest that at this point the treatment is different. I hope that's what you're expecting. How does tonsillectomy affect occurrence rates? I don't think so. It doesn't really affect. In recurrent cancers, the role of vaccination, again, there's no evidence to suggest that. It's a trial in Australia. They're starting with immunotherapy. And you could ask this question with Valerie in the panel 3. They are discussing mainly recurrent cancers. Great presentation, thank you. That should be in the chat, please. And can the GP can be contacted to arrange a vaccine for teenage boys who has not been given HPV vaccine before they are sexually active? Yes, I think, yeah.
Thanks, Jay, and fantastic presentation. So for those that don't know me, Jim Moore is my name. I'm an ENT consultant in Leeds in the UK. I'd just like to ask you about the systematic review and the meta-analysis that you presented, which was published last year.
Yeah.
So in RMDT, for patients that are suitable for TORS, then they generally get offered a choice between primary surgery and possible adjuvant therapies after that, or primary chemoradiotherapy.
Right.
But the meta-analysis that's been published shows a distinct survival advantage for those that are suitable for TORS.
That's true.
So should we be moving away from offering these appropriate patients a choice of treatments, and should we be offering them primary surgery as a de facto?
I think that's my consensus, or my understanding is going to be early T1 and T2 N1 cancers. It's very similar to be treated as a transfemoral laser surgery or radiotherapy. So many patients would take laser for laryngeal cancer. It's going to be the same for HPV positive cancers. They would consider surgery as a first modality of treatment. Yeah, the answer is yes, but the oncologist, I'm a little bit.
The basis for meta-analysis.
Yes, as well. But again, the meta-analysis is a good one. I reviewed the paper again and again. It's a good paper. The only difference is there are 4,000 patients, chemo-RT, 1,500 patients, robotic surgery. But again, they have carefully applied the statistics, so it shouldn't be a big issue. But still, more and more papers is coming out. But definitely, it's not inferior.
Hi. Just a comment. I'm Silke Schrivis from Hamburg. I'm a radiation oncologist.
I knew that.
And I just came back from the ESMO meeting, and I think with the HPV-associated oropharyngeal cancer, we have to shift the treatment paradigm completely. So the way I grew up 30 years ago, it says we have to restrict modalities. So ideally, you have one modality and not the tri-modality treatment. But from the HPV-associated oropharyngeal cancer, we know whatever you do, the patients do better. And the presenter said something like in the conclusion, yes, surgery, because it gives you accurate staging. It's like the neck dissection is not only therapeutic, it's also diagnostic, because we have radiation oncologists. We look at the MRT, we look at the PET scan, and it's the node positive, negative. So it has surgery, I think, definitely has its role. But the goal should be to de-escalate all treatment modalities. So the trials are going on doing surgery. You need less dose of radiation. You might be able to omit chemotherapy, and then you have less intensity for all modalities. I think that's the way we have to go. It's not either or. So you don't want to give 70 gray if you can do it with 50 gray, which beyond 50 gray, the toxicity rate is increasing dramatically. So I think that's where we have to go.
Absolutely, I totally agree. And I was talking to Professor Pellery, he was saying that the recent trial in USA, after surgery, they're giving 30 gray in case of positive margins and other things. So it's even much lesser, probably it looks 2 weeks radiotherapy or something like that after surgery, which is much better than 6-7 weeks of radiotherapy and other things, knowing that the cancer is has got a good prognosis. Yeah, great. I think I'm done. Thank you very much. So.